Hello, everyone. So, I did my case study on septic shock, complicated by a urinary tract infection, which led to urosepsis. This case study involves a patient demographic of a 75-year-old female, Betty Smith, who has a past medical history of type 2 diabetes, hypertension, recurrent urinary tract infections, stage 3 chronic kidney disease. She is a retired social worker who lives a sedentary lifestyle and just returned from a 2-week family vacation in the Bahamas. Her current medications include metformin, insulin, atorvastatin, lisinopril, and metoprolol. So the chief complaints of this patient are frequent urination or dysuria in the last 24 hours. She has lost her appetite, has experienced some nausea, vomiting, is feeling very tired. Her son found her at home a little disoriented. She has fever of 103, chills, and the son seems to be confused. So he takes her to the emergency room. So clinical presentation for Betty Smith. Subjective information was limited due to the patient's confusion. She was alert and oriented to self only. Complaints of bilateral lower flank pain and tenderness or costovertebral angle tenderness was noted. Intermittent shortness of breath or difficulty breathing. Altered mental status, as I said, accompanied by nausea, vomiting, and complaints of headache. Her vital signs included hypotension of 80/40, tachycardia of a heart rate of 133, a respiratory rate of 26, and her O2 stat was 88% on room air. Upon physical assessment, her skin was warm to touch with bilateral lower leg edema and shortness of breath. So for 3 differential diagnoses, the first diagnosis would be urosepsis related to a complicated UTI. Risk factors include the geriatric age and a history of recurrent UTIs, the bilateral flank pain and tenderness, and her comorbidities of type 2 diabetes and chronic kidney disease. Diagnostic tests that would be used to rule out a UTI include a urinalysis, routine blood work like a CBC and a CMP, along with blood cultures and a lactic, possibly an ultrasound of her kidneys. These systemic symptoms related to a complicated UTI include the hypotension, fever, tachycardia, and tachypnea. Along with her altered mental status could indicate a alternative viral or bacterial infection. So the second option differential diagnosis I chose was community-acquired pneumonia. This is due to the patient's complaints of difficulty breathing, her low O2 sat of 88% on room air. She does also have systemic related effects, like I mentioned previously, of the hypotension, tachycardia, and tachypnea, which could be indicative of a systemic infection from a bacteria or virus, although she's not complaining of any cough. Upon assessment, I would order diagnostic tests to rule out pneumonia. Would be a chest x-ray, a sputum culture if a cough or sputum production was present. Again, a CBC and a CMP along with blood cultures to indicate the source of the infection. So my third differential diagnosis would be meningitis due to the patient's recent travel history could indicate that she was exposed to some type of virus. along with her altered mental status accompanied by fever, which could indicate an underlying central nervous system infection. Diagnostic tests that would be used to rule out this diagnosis specifically would be a lumbar puncture to test cerebrospinal fluid, blood cultures, again, a CBC, a CMP, and maybe a CT scan of the head to rule out any inflammation of the brain or the spinal cord. Symptoms, however, for meningitis that would indicate this as a definitive diagnosis would include things such as neck stiffness or complaints of photophobia, severe headache, fever, nausea, which she is complaining of, confusion, and a possible rash or small round spots that indicate a rash or a pedicay. So of the three differential diagnoses, the likely diagnosis that I chose would be pyelonephritis, a type of urinary tract infection which led to urosepsis. This is due to the patient past medical history of frequent UTIs, her complaints of flank pain, along with the new onset of altered mental status and signs and symptoms of systemic sepsis. Diagnostic blood work that would be ordered for a definitive result could include a urinalysis, which may show E. coli, a common bacteria shown in UTIs, along with leukocytosis, increased white blood cell count. We would also check blood cultures, a complete metabolic panel, and lactic acid levels for evidence of sepsis or end or organ dysfunction. Because she was not complaining of headaches, cough, or any lung abnormalities that may have been seen upon chest x-ray or a CT scan of the head to rule out meningitis and or pneumonia, those diagnoses were ruled out. A definitive sign for pyelonephritis or any type of UTI could be the costovertebral angle tenderness, which she was complaining of. So the pathophysiology of a UTI, Rogers explains as inflammation of the urinary epithelium or mucosa, which can be caused from bacteria. A UTI can occur anywhere along the urinary tract, of which includes the urethra, the prostate, bladder, ureter, and or all the way up to the kidneys, seen both in men and women. Although women commonly experience frequent UTIs just due to anatomy and a shorter meatus. Leukocytosis would be present and can involve decreased vascular resistance, which leads to hypotension and less perfusion, which can result in organ failure if severe sepsis occurs and goes untreated. Again, underlying comorbidities which this patient presents of recurrent UTIs, diabetes type 2, and chronic kidney disease can impair one's immune response. The infection, which could begin as a UTI, can spread from the urinary tract to the bloodstream, which would trigger the systemic inflammatory response, or SIRS, which, if goes untreated, turns into severe sepsis. Again, as I mentioned previously, disease progression could include the complicated risk factors Betty presents of diabetes type 2. Hyperglycemia can impair neutrophil chemotaxis and phagocytosis, along with the cytokines that are responsible for stabilizing microbacteria in the urine. Again, chronic kidney disease can also impair renal function and renal clearance, which compromises perfusion to the kidneys, glomeruli, and perfusion. Systemic inflammatory response can initiate a cytokine cascade, which triggers endothelial dysfunction, leading to vasodilation, which triggers cardiovascular responses such as hypotension and tachycardia. Again, organ dysfunction can also be seen in hypoperfusion due to vasodilation and a declining glomerular filtration rate, which impairs kidney perfusion. So immediate treatment for urosepsis would begin with broad-spectrum antibiotics such as vancomycin or meropenem until the urine culture and sensitivity came back. You would want to begin immediate fluid resuscitation for hemodynamic stability due to the patient's hypotension and tachycardia and systemic related effects. You could also give analgesics to combat the patient's fever and flank pain. If hypotension was to continue upon administration of fluids, the patient could also be put on a vasopressor to increase the blood pressure. Continued management and education for this patient would include to monitor urinary output and her glucose levels related to her type 2 diabetes. We would also want to check renal function to make sure that the antibiotics are not worsening her chronic kidney disease or her GFR. I would educate the patient on staying hydrated and drinking plenty of fluids to help flush out bacteria from a UTI, or taking non-pharmacological over-the-counter medications such as a cranberry pill, which can help with the pH and acid levels of the urine. I would also include dietary changes that are rich in fruits and vegetables to support urinary health, and safe hygiene practices to make sure the patient is properly preventing future infections if the infection was indicated from a bacterial infection and not any type of urethral obstruction. That concludes my presentation on a complicated UTI which led to urosepsis. Thank you very much.